certified in the March. So also with the convenient CT video, is very convenient and efficient in the digital dentistry works, and that will be introduced by Professor Park. Thank you. And we have developed and finished the implant system over 20 years ago, and 20 years, and those at the time, and we tried to find the simple and efficient way in dental implant. At the time, the final goal ours is implant tourism can be possible through the minimize invasive surgery, efficient distal work, and with the all-roading concepts. So we have the rest of the 20 years very passionately tried to develop various materials. So when you think about the implant in the next, must be a short and narrow, especially that would be very fitable to the treatments people also together. So surgery must be a very easy and painless and predictable, and also distal must be simple with a very low investment and high quality, and also if possible combined with the filler and the toxin is very efficient for the implant patient. It's because about the Botox treatment, and it became much more popular in our office because the many crunching process patient of the implant patient. So with the combined with the Botox is very helpful, and also after the age there is too much wrinkles around the lips, so we do augment it with the fillers of for the implant patient. So finally, implant can be easier. Yes, it can be much more easier compared to 20 or 30 years ago. Still very complex with some of the surgeons to bone grafting and others is too much complexly. So it looks fine, but daily practice it was very difficult to apply the concepts. And also about the complications, if we became simpler and easier, there will be much less complications, and also with the design and surface treatment upgraded, so all loading can be possible, and also with that, and finally, the treatment cost became to be lower. Is about the narrow implant is very convenient in the anterior regions, and the short implant in the posterior upper and the lower, and also this new system of the bright implant can be early loading and also can be used for the worsening treatment. It is a long history of the development of the dental implant from the implantium, and we do very continuously concentrated on the development to be simplified. And at the time of the 2013, we tried to design an line to be simplified, but still some problem of the fractures. So also tried to slimline, but that implant also have some prosthetic difficulties. So we tried to make a new system, this converse of all of them, and finally we are launching a bright implant system that is a tissue level, that is a bone level. Of course, this is not the end, and also through this one we will continuously, but with this one the treatment became to be much simplified and easier. That's a tooth system. One is the bone level, we call it the DL, and the tissue level is also, we are calling it as TL. Especially the tissue level implant is the screw joint is only optimal side, not so much below in a distal side, so relatively higher strength compared to the others. Evening tooth diameter is 3.5 can be used for the molars, and also diameter is 2.5, sometimes 2.0 can be used for the anterior regions. And also about the also bone levels before with the supine implant. One example is that connection is 11 degrees, but nowadays with the 10 degrees much less screw loosening, and also the connection is optimal is not fixed, is not only fixed to the screw retained, also itself is very well stabilized, so not so much dependent on the screw tightening. So it's a bone level due to the connections is a limitation of the internal connection systems is a diameter from the 30.5 and 6.0. And as you already mentioned, is a very deep connection. It's a 10 degrees, means not so there are no screw loosening. And much less sink down. Sink down is much less compared to the previous one. And also thread is a little bit thinner and longer. However, that is a short implant, have a strong enough surface to endure the loading of the molars. And the surface treatment a little bit upgrade compared to the short prime for the fast bone formation for the early loading. And the rest is a little bit different because the bright implant system one is a narrow diameter, drilling only to the cancellous bone, not grinding out the cortical bone. So the drill system little bit changed it, very big changed it for the cancellous, only cancellous bone drilling. This is a bone tissue level implant, is diameter starting point from the 2.0 to the 5.0s. In this system, in diameter can be used very well in the anterior region. And from this one is very safe to the molars. One example is in the molar regions. It's the first molar. This is the first one. Yeah. And this one little bit shrink, but drilling on the cancellous diameter 3.5 very good. It will overcome the bad forces. Because the 3.5 tissue level implant is strong enough to endure the occlusal forces. Much more with the magnifications, and in the tissue level 3.5 can do overcome the occlusal load. Also, with the design upgrade, we are trying to upgrade the designs, even in the bone level implant still. 3.5 cannot use so well, but now after the overcoming that problem, we will try the even to bone level can be used in the molars. Also, to the diameter 3.5 can be used in the molar one that is still homework to overcome. So, but we are trying to continuously design upgrade it nowadays. And is a tissue level thread designed to be dome shape to have a much more surface contact with the bone. And so finally the diameter is from the 2.0 to the 5.0 diameters. And about the connection with the hex, but hex has some problems, not only the screw loosening, and also some gaps between the fixture and the abutment, so bacteria can penetrate it, but with the 20 degrees, the connection is very stable, and so if you use the hexing this month and there is no screw loosening. Also, surfaces are very similar, drill are similar. So another difference between the previous one and the bright implant system is in the drillings. And as you see, before the surgery, usually we check the thickness of the bone cancellous bone, and depend on that we decide the implant diameters. And before, we usually followed the dependent on the implant diameters, and we select the after that we have done a drilling. But nowadays we have very different approaches. Depending on the cancerous sickness, we select the implant because the implant became stronger. So only cancerous drawing without violating the or grinding out the radial cortical bone. Also, ultimate ultimate is designed for the distal oriented. So that is very convenient. So with the healing ultimate, we through the bilateral impression scanning concepts and with the virtual making a model and the virtual vessel and the final processes with the whole is a modelless. Previous the modelless concept only used for the single crown, but with the CT, combined CT viewer and the digital concept in identitoscanesis also can be treated with without models. Also, we can use the intraoral scanners. So, about the digital dentistry very nowadays confusing. In a small case is fine, but from the small to the extensive cases, there are too much controversies. But nowadays, with the developmental engineering, the difficulties continuously upgrade is overcome. Anyway, this is a distal abutment. It's a tissue for the tissue level. This is a rear bone level. So neck is top is the same. That can be used for the healing abutment. Also can be scanned and also can be impression copying, or sometimes can be used for permanent. That is with only one abutment is have a very diverse functions. And this is a tissue level implant. A bone level implant with a conventional screw abutment. We can use diverse screw abutment options, and also this BL also can have its own abutment systems. So our goals of the treatment is with a short and low implant is a minimally invasive surgery, and also impression scanning with a model scanner or intraoral scanner, and we have a very good imagings, and finally the process of treatment can be a modelless approaches. I will show you some clinical cases with the narrow diameter at first, and then next about the short implant. Due to bone loss, we tried to extraction, and after healing of the bone, yes, so and after that we placed the implant, and finally we made the final processes. So there is a interproximal bone loss, so I decided to extraction at first, waiting for the bone healing. So after the healing, we can see some collapse on this side. So it will be lingualized incisions to push the gingiva to the lateral side. And in anterior, after healing of the instructions, and so we can see some bone loss on the radial side. That is the cause of the bone loss. So we placed a very small diameter implant on this side. That is the diameter is 3.0, and the length is 11 millimeters. And very simply placed without bone grafting and making it temporary. And after that, and with the instruction of the anterior implant and making a bridge works, also process is done by the scan healing abutment. And with that, before also we use the impression copyings and with the model works, but nowadays we try to modelless works. So, but sometimes with the intraoral scanning, some errors. So at the time we need to bilateral impression concepts, and for the right can be approached to the end, and so the border cutting. And sometimes the ultimate is the narrow and the longer. It was very difficult to do impression scanning, but if short and wide is much more easier. So in these cases, we do first scanning to on this side after the trimming out of the impression, and the second scanning at the time of second staining after trimming, and the right can be approached. So combine of them, and we can make final scanning of the even in the narrow and the long wall abutment. And then from that, and we can make a virtual model and the virtual setup, and after from the temporary to the finals and pressed into the mouse, and the treatment was finished without borderless. So I'm a periodontist, so sometimes I am think, and from if we started try to make a model, at the time some errors became to be started, but without borderless approaches, even some vertical dimension increased cases, treatment became to be much more simpler. It's a pin guide. This was invented by the Dr. Hyun, is a Hyun Young in Korean doctors, and so he put the pin guide on the buccally and the lingually to check the bone width. After that, without the flap elevation, he does the ring between the labial cortical bone and the lingual cortical bone, and very simply pressed in the cancerous with a narrow diameter, and this is a very minimally invasive surgery. When you do pin guide insertion, we can see that the lingual, very fortunately, bone width is very thick, so we do press the very small diameter implant to the lingual side, and with that, surgery was very simply finished. In the clinical, we use after instructions and the 2 implant, and the implant pressed only to the cancerous regions, and without violating the labial cortical bones. And after that, after the final processes. And this is a video of the previous. Sorry. Okay. Due to time, so I will go fastly, skip off this video. And this is another cases with the extraction of the anteriors. I'm sorry, different cases. So extraction of the anteriors, and also press the 2 implant, and in this side we did the socket preservations, and the extraction side covered with the collagen graft 2 and the suture, and 1 year later, rapidly very fast healing. That is due to collagen graft 2 have a very good tissue healing potential, and also PDLN is a DNA, and is a soft tissue healing 2 times faster. So it's a 1 year later. And with the temporaries, especially in the curved arches and the edentulous, we do intraoral scanning for temporaries. And after the temporary incisions, and 1 year later, we are a little bit worried about loading, so sprinting to the adjusted natural tooth. Some months later, after the complete healing of the soft tissue, at the times we did BTS concepts instead of the iOS. That is due to that is sometimes the intraoral scanner have some error, is a curved situation and with a pond edentulous situation. So we use the BTS concepts, and with them making a virtual model, virtual setups, and the zirconia milling, glazing, and then pressed into the mouse and was finished. Sorry, it's some. And also in these cases we do instructions, and I'm sorry, a little bit confusing of the slides. And with the 2 implant, after instructions, in this situation there is too much periodontal disease, so we place the 2 implant in the lateral incisors, and in the middle areas we try to do socket preservations. After that, the some bone grafting and the collagen graft was covered after sutures, but we tried to early temporizations. So during the process, we are doing some traumas of the surgical site, but with the virtual model, and this temporary crowns printed together to the adjusters. After the stitch out and healing, and at the time of the final, also we used the BTS concepts because this COVID situation also event was two teeth was missing, so for the pre-season, and we used the model scanner for the vital traction scanning with the model scanners. We made the virtual models, and we taking a combine CT with the CT viewer, and from the we taking a STL from the DICOM file. DICOM file is a 3D images, is a surface images, so we can do stitching together. With the stitching, we can make virtual models and the virtual setup. And on a virtual articulator with the occlusal adjustment in century and eccentric. And at first PMMA block for the temporaries, but this is for the final zirconia milling. And with the grazing was finished and pressed into the mouth. And in the upper four anterior tooth and the lower four crowns with the implant supported. And also we can test from the compensity via midline, sometimes with the ideal occlusal frames, and that is very helpful for the virtual setup of the tooth and the crown. Maybe this is a video of the lower anteriors. It is very common in the lower due to mobility of the anterior tooth. At first we use the resin printing for the news, for the maintain the lower anteriors, but finally two anterior tooth became to be instructed. So it's a with the clarifications, instructions. Already due to periodontal disease, the tooth was instructed. So after the instructions, after that, there are many granulation tissues after instructions, so we decided for the complete of removal of them, it is better to make an incision and to complete removal of them. And we tried to place the implant on the lateral incisor area, and after the clear cut the periosteum. As a concept of the minimal invasive surgery, flap elevation not to be so much over the mucogingival junctions to reduce the surgical trauma to the patient. After the complete removal of the soft tissue and the drilling was started, and there is a missing periodontally destructive site was filled with the osteum collagen, and also with a little bit of preservation also to the implant side, and after that 3.0 diameter implant was placed. Due to defect, a little bit deeply placed. is a tissue level implant. The cover screw was removed and the insertion of the healing abutment. We selected a little bit longer healing abutment due to implant was a little bit deeply pressed. So this healing abutment is there is one side is some flat surface that can be used for the scanning, and collagen graft was used to cover the bone grafting. And without peristylene incisions, and the collagen graft was open, and also with the minimal invasive surgery concepts and the PDR injection after surgery, and the surgery was finished. And this is another case of the video with the narrow diameter 2.0. The patient have a very diverse experience of the implant treatment in some part in our office, some part is another office. But in the anterior bone is too much thin, so patient come again for the treatment of the lower anterior. So before the treatment we began to know that the labial and lingual bone is very shallow. So if with the narrow diameter implant is very helpful to press. So as very similarly to instruction, the reason I show you this video is that we had pressed the 2.0 diameter implant. Compared to the previous videos is 3.0, and also we can use the 2.0s, but 2.0 is very narrow, so with the temporalizations and some record converted into the final processes after instructions. And so sometimes immediate implantation into the instruction site is some 10% is more failure, so we do aggressive irrigation in after instructions, and sometimes degranulations, and also sometimes chemical or heat treatment with electrosurgery or laser treatment. So trying to complete through removal of the infection source with the aggressive irrigations. And in this case, the lateral side is bone quality is not good, so we tried to press the central incisor areas with very narrow diameters, so positioning with the high-speed surgical bursts and the bone grafting into also the lateral incisor area for the socket preservation, and also central incisor area to fill the gaps between the picture and the labial bones. After the very packed posterior collagen was to the instruction site, and also some positioning of the implant features for them is a little bit, not completely, is a little bit more drillings. And then after that, 2.11 millimeter length implant was placed. So in a very narrow bone, sometimes it's a narrow diameter implant is very helpful, sometimes even into the dangerous patient, because they need is dentures. Sometimes, one example in the denture patient, alveolar ridge is after resorption very sharp and short and narrow at the times, and also we can do same segmentation of bone graftings. But sometimes with the narrow short implant is very helpful, especially in the extensive pontics situations. So after insertion of the distal abutment, And also instruction site was also collagen graft was insertions. About the collagen graft, we tried to imitation of the fibroguide, and the next innovation is a dense collagen graft. Third innovation with the suturable collagen graft to replace the ADM. So most of the development is from the imitation, innovation, finally creation. So about the bone graftings, and nowadays membrane collagen graft, and also osteocollagen, and sometimes the collagen graft combined with the osteocollagen. And so through the innovation, we tried to make the final creation materials with the gradation of the collagen graft materials. And after suture and they're finished, patients have a very diverse history of the implant. But anyway, we pressed into the cancellous area very simply. I'm sorry, this to be shambled due to too much problems of the previous implant. To implant. And then after that, we did the intraoral scanning. This is a photogrammetry. And for the temporaries, in the anterior side is very narrow, so we have used the tie base that has a 50-degree angulation screw hole, but for the temporaries, and we're making a screw on the radial side. But for the final, we can convert it in the lingual side, 15 degrees. But for the temporaries, in the radial side is fine. So that was sprinted together in the lower anteriors, and after the some complete healing of them, so we finally converted in the final processes. Also in the upper anteriors, bone is very narrower, so at the time we tried to select the implant diameters to follow the cancellous areas. Also with the implant pressed on cancellous areas, and some contour augmentation was done. And during the 2 months later is some contour augmentation, and the treatment was finished in the 2022, and after instruction is a very natural healing of the little bit collapse on the radial and the crest ray. And also with the pin guide, we check the radial bone and the lingual bones, and we try to press the very narrow diameter implant 2.5 in the areas. Without exposure of the fixture, we did only contour augmentation on the radial side with the osteocollagen and the collagen graft 2. And 1 is later. And with the temporaries. And for the finals, we use the PTS concepts. With the zirconia building, glazing. This is a multi-layer block, so without any coloring and staining, we have finished. Also in the single cases, we selected a very narrow diameter without anyone, and we only incisions, little bit palatally, very narrow diameters. And for the finals, we can do 15-degree converted into linguals. This is some of the case, little bit converted to screw holes in the anterior side like that, and we change the screw hole to the palatal side, and it's finished. It's anterior, and the others will be finished with the modulus with the multi-layer blocks. and the anterior. Of course, with some grafting, we can fit the interproximally, but if the young ages, it is good to fill these spaces, but most of the implant patients nowadays in Korea is very old ages. It's an average of sometimes over 70 years old. So in a very aged patient is usually food infection is in various sites. So sometimes we do not do anymore. So due to main reason, we finally do extraction after healing. In this situation, you can see some bone defect, vertically and horizontally. Sorry, after implant placement. On this side, with some contour augmentation, little bit vertically and horizontally. Also, bone was very thin. We pressed the narrow diameter implant. So we put the surgery in the canine areas due to a little bit defect. So we tried to make a little bit ringularized incisions. And yes, the semilunar incision also for the augmentation for the soft tissue with the little bit palatal position incisions. In the anterior side is due to proximity, we tried to make a simple design with a narrow diameter. And with the semilunar incision, little bit palatal position incisions, and the placement of the narrow diameter implant. And without the flap elevations, very simply finished. And also for the augmentation on this side with a little bit vertical incisions for the augmentation, the crestally and the radially, with the membrane insertion and some osteum collagen was inserted very densely packed, and the suture was finished. For the temporary at the times we use intraoral scanners. Sometimes it fit well, sometimes it's not fit well. So after healing with the temporaries, after the complete healing of the soft tissues, we did impressions for the final processes. At the time, in a point cases, BTS is better. And cementation inside the mouth. With the cementation outside the mouth after the trying of the processes, screw tightening is not passive. So for the passive fit, depending on the bridge sizes, we do control the cementation gaps, cement gap. One is the Oronex cross arches, so sometimes we are 100 micrometer cement gaps, and with the cement before the setting, pressing into the mouse and setting into the final processing into the mouse, it may be a very passive fit of the screw tightening. So sometimes they are due to prevent the errors, and we do temporary with the automatic without the cement and put into the mouse, and the waiting 5 to 10 minutes for the adaptations of the final processes to push the gingiva very passively. After the cementation and the final cementation into the mouth, with the final cementations, and the treatment was finished. So sometimes, if we do bone graft, we try to avoid. But if we do bone graft, we do minimalized. So in the upper anterior, usually say in the upper anterior when you do incision like this one, but when you check the CT on the buccal and the lingually, if you press the very narrow diameter, we can do pull-up-rest approaches. But at the times, we must check the radial bone. Without very dangerous, sometimes the living is outside the bone housing. But with the narrow and the inside the bone housing is very critical for the minimally invasive surgery. And also in the canine areas, due to some tearing, usually in the implantation, immediate implant, in the anterior there is many gaps. So sometimes we do coverages or not. We do also various material can be sometimes membrane, or sometimes collagen graft, sometimes subconnective tissue graftings. and after the finishings. And at this time we do cover with the collagen graft tool. And before the drilling, and we check the radial bone and the lingual bone. So we try to push in between the radial and the lingual bone side. And they place the 3.0 implant. And on the canine side. But during the instruction, unfortunately, some tearing. So that's the reason we try to collagen graft coverages. Before the insertions of the implant, we do some osteocollagen packings. And after the implant placement, and the collagen graft top, we are pushed into the gaps, and the suture was finished with the intraoral scanning. And the temporaries, and this is a natural tooth, and the 3 implant, and connected to the DDS tooth, and there was a sprint togethers for the early temporarizations. And then after the complete healing of the tissue, we tried to do BTS for the finals. Yes, one is after impressions and border cutting. Sometimes one time scanning. If not enough to write, can be approached to and after the treatment of the impression, second time scanning. Through the stitching together, we have a virtual model. And with there is a virtual setups. And also CTVO, during the development of the CTVO, we tried to find such as the AI occlusal frame and the midline. And also before CT was used for the diagnosis, but with a much less X-ray doses now, this can be used for the treatment. So with the AI occlusal frame, it's very easy to purchase setups for the modelless approaches. And also with from the DICOM we have STL, and we can see the midline. And sometimes ideal occlusal frame, the offline clear virtual setups, and is very, with the CT viewer is very helpful. And also we take 2 TS in the 2 times. At the time we have much more differences. But without that, and also we can do check the midline from the ANS, PNS line, and on a virtual articulators, and the occlusal checks. Before we are not so much have a confidence for the virtual articulator. But nowadays we are many is a vertical dimensions. Increased patient is with the virtual articulators. At first we are not confidences, but nowadays we have a confidence for them because the relative very good occlusals. And for the finals, just nowadays we are 3-layer zero cornea block, and without no staining, no glazing, only no coloring, and only glazing, because translucent value differences, and without additional procedures, we have finished and placed into the mouse. This is another patient in the upper anterior. Very short implant and very narrow implant, because patient is very high ages, over the 80s. So patient wanted to finish the surgery very simply after instruction healing. Alveolar bone is very thin, so we try to press the implant in the very thin alveolar ridges. Some contour augmentations and the socket preservations. And press the 3 narrow diameter implant, and the treatment was finished. Is the intraoral scanning. And stitching with the CT viewers, we tried to make surgical guide. The screw for the temporary with the screw hole on the radial side to follow the bone contour. and that was pressed into the mouth and the drilling and the surgery. So that commonly use these concepts, but with the drilling and the is grinding and wash the resins, and we try to make same day temporizations and also connect the DDS tooth after the cutting of them. So we are nowadays trying some drill system for the crown guide. After that, and the placement of the implant in a very thin ridges, and also instruction site. After grinding of any soft tissues, and the bone was very thin, but lingually, we selected the narrow diameters. These are 2.5 millimeters. And another 2-point diameter implant into the not healthy instruction site, but instruction site, the content defect is very usual to the bone regenerations. And the 2.5 implant was pressed, and so exposed the fixtures site is a particulate bone and the osteocollagen together, and the collagen graft covered, and the sutures and the PDL injections, and finished. After healing, scanning for temporaries, and with the virtual model. At the time we taking usually we take a CT on this part, but there is if we take another part automatically, if you want the more reference, and we can have a larger FOV. And with this step, interpupillary line follow the interorbital line, and midline from the nasum, ANS, PNS, we can know the midline, and with that, with the virtual alignment, from the PMMA was at first, as PMA temporalizations, and after healing of the tissues, we try to make finals, BTS, and the already mentioned CTV suggests the AI occlusal plan and the midline that is very convenient for the upper anterior tooth alignment. During the alignment, the patient is aligned, midline is shifting one. Sometimes also we can know the Ewing one, tilting, everything we can know from the CT images. So with the virtual articulator and checking, and the final, because patient is very aged, so we try not to screw on the lingual side. Is very over 8 years old, so we try to the simplest is making a screw on the labial side. A little bit is a different characteristics, but it's fine because with the breasting, with the 10 NDP, primer, and the cement resins would be fine. So after the final treatment, and that was finished. This is another next approaches. Due to periodontal disease, we have extracted of 2 anteriors, and bone is very thin. So before the surgery, we are thinking about with the pin guide to making a flat elevation or not. But at the time, is with the pruning, so pruning is naturally penetrating the instruction side, so it is better not to do flat elevation would be good enough. And so we check the labial bones and the lingual bone with the pin guide. Also, patient have some medical history, so it is better not to make a flap elevation. So we pressed on a pin guide and very gently drilling into the destruction side. Sometimes the pin guide is helpful, so positioning of the pin guide is very important. It's not only the check the labial and the palatable, also implant positioning guide. Also, we are now testing about for the overloading is the rigid spread drills. 2 feet only the final thread of the fixtures. This tribute is a tapered styles, not completely fitable to the fixtures. Is a top in the crest cervical side is much more fitable to fixed, but in the upper side much more tapers. So 3.0 implant was 2 implant was placed. Very simply, without flap elevation and suture, just to only scan healing abutment, and through the scanning, we try to make final processes. So after this was finished, so I go to the, I'm sorry, go to the next one. After that, when I check the mobility is good enough, so we try to scan for the femoralis, but not net of applied that, because there was the recent cases. In the posteriors, due to periodontal diseases, we have instructed. So usually when you press the implant, without violating the labial cortical bone, and only drilling into the cancellous, diameter 3.5 millimeters. After that, finished with the final processes. So as you already know, after healing, mucogingival junction to the alveolar crest, but if you do little bit angularize the crestal incisions and push the little bit gingival on the labial side, without any contour augmentation, very simple and helpful. And of course, is a little bit less compared to the others, but is practically is good enough. So is even in a small defect, and it is very simple surgery. So with the bright implant system, with the narrow diameter and the short implant, there are very diverse approaches in features. In the posterior side, already seen, and the 2 implant also pressed only cancellous areas, diameter 3.5 millimeters, and it is very common after healing. So we try to make our incision is a little bit angularized incisions, and push the gingiva to the labial side, and after insertions, and already you can see there's some augmentations. And after healing, patient cleanses so well, so there is no need for the additional grafting. Also in the lower, after extraction, and the 2 implant was placed. So this is also another cases after due to periodic severe extraction and the baking counterlevels. So socket preservations. And also this is a supine case, supine. This is the same supine have some healing scan of process are same, very similarly. With the final process was finished with the BTS. Sometimes the iOS in the trained cases occlusion is not so much precise, but with the BTS concept, the occlusion is much more precise. So also in this patient, with the previous X-ray, due to some computer problem yesterday, I didn't finish well. And anyway, through the healing abutment, to define BTS and the occlusal adjustment on the virtual articulator. In case we can see that little bit premature contact on this side. So after setting, a little bit more adjustment on this side. Almost every size are very similar in a virtual models because that is due to BTS. With the intraocular scanners, nowadays with the photogrammetry, much became to be much better, but still little bit less compared to the BTS. So in these cases, it's very bone one was too much thin. So with a narrow diameter and modify the healing ointment, tuck in the collagen graft and the flaps all together. So before some grafting, and after that we had to press the implant. In this case, it's a very longer implant, is a little bit more risky, but in a CT it was safe. But as you see, there is some vertical defect and some horizontal defect because the previous implant was failed. That was placed by myself. So at that time we tried to implant and little bit vertical and radial contour augmentations with the collagen graft and the osteon collagen sutures, healing with not intentionally peristaltic lesion incision, very fastly sutures tugging below the healing ointment. So with that we have a much more gain of the keratinized gingiva. It's very helpful. And then after that, little bit more contour augmentation on the radially and crestrally. So with the virtual temporalis at first, and after the complete healing, and the BTS only one side. It is possible at first we are a little bit hesitated, so most of the cases in this situation you must do full mass impressions, the upper lobe and the periphery size check bite. But if, however, in the BTS concepts, only one check bite, and there was occlusal adjustment also on the virtual articulators. And this was the previous model with the overlapping together of the provisional crown. But even in the finals, and some, not so much enough impression, but with the virtual stitchings, and we making final processes. And the pressed into the mouth, occlusal fittings is very precise. Even in this case, usually, however, with the full-mouth impressions, and but sometimes with the models, and there are too much occlusal adjustment. Also, occlusal means not so much fit webs, but with the BTS and the occlusal is very good. And unfortunately, with any occlusal adjustment, Shimstock is fit very well. Sometimes in extensive cases, if we cannot avoid the bone grafting, we must do with the titanium meshes. So there is a continuous need for some extensive cases how to make bone graft very simply, and to also securing the good bone quality. So also we need to continuously develop about the concepts with the materials and some surgical concepts, because still in an extensive case surgery is too much complexes. So with the various approaches with the sometimes 3D printing of the plate and 3D printing of the bone graft materials, because we have many development system of the bone graft printing and the metal printing and the others, but to be simplified and not to be so much customized approach is very important for the efficiency. So in these cases we do conventional plate, and then there is just shaping and the screw tightening, stabilizations, and over there is a collagen membrane covered and the PDLN. Some is also grinding out and heated. At the time of the second stage surgery, we see the little bit less bone augmentations. So after implantations, with a little bit more augmentation on this side. Second stage surgery, temporaries. With the temporaries, and there is not ideal mucogingival junction, so after in this case, a prosthesis was done by a prosthodontist of my colleagues, so he do follow the conventional concept, so he used the impression copying and finished, but not so much good controls of the mucogingivals, so after checking the tooth brushing, if not so much good, you must do mucogingival surgery. So in this patient, after extraction of the previous implant, so we must do the contour augmentation vertically and cervically. So we do little bit contour augmentations, the before, after. Also a little bit vertical augmentation too. It's not so much defect, so with the simultaneous approaches. So at the time of the implantation and the bone augmentations, sutures, very common after the GBR. So at the time of the surgery, also we did not do any periosteal ridging incisions, only grafting suture was finished, and mucogingival program was not so much serious. But 6 months later, when I did the surgery, I a little bit hesitated to simple surgery or mucogingival surgery together. So at that time, it is patient relatively young ages because usually my patient is over the 70, but patient was almost 50. So then we tried to make mucogingival surgery and do that stabilization with the pin. And also there is no keratinoid gingival on the natural tooth, so I did a pre-gingival graft, and that was fixed with a pin. And for the patient comforted with the Copex, but nowadays we are developed the resorbable packs. So later on we became to introduce anyway with the pins and the root coverage. 1 year later, 2 years later, it was 2 years later, sorry, already became to be stabilized for the root coverages. So 3 weeks later, much better. So in a mucogingival surgery, pin is very helpful. Without any grafting, only apically positioned flap, only grafting for the root coverages. It is very helpful nowadays evaluations. This is also in the uppers with the unilateral dentures. Is very common in edentulous patients. As you see, alveolar ridge is very thin and short. And with some sinus grafting, we select the implant diameter is 2.5, diameter 3.0, diameter is 3.5 with 1 cantilevers. So before alveolar ridges was very shallow, but became to be widened with temporaries, and finally converted with the finals with the BTS this is introduction of the BTS, but anyway, and the virtually settled, and the final process was flashed and finished. Sometimes also we use the 3D printed bone with the hydroxyapatite combined with the beta TCP. But for the strength efforts, we tried to select the hydroxyapatite and also surface coated by the beta TCP. And it looks nice with the sinus segmentations, with the finals. Before and after looks fine. Yes, with these images, if for the vertical augmentations and with the 3D printing would be very helpful. Yeah, it was a very good result. And also there was stabilization with the screw, additional stabilization with the membrane, healing, sinus segmentation together, and the suture and was also sometimes the mucogingival junction too high, so lingualized incisions push the gingiva to the lateral side, healing. The final process was finished. Patient cleansing very well. But also in this patient is very similar, but at the time we did not check so much. This patient have a very strong clenching habit. Bruxism patient during the night maybe tongue force is too much. So after surgery we have many difficulties to disposal of 3D printed graft material. So finally we are converted to conventional GBR concepts. And there's too much exposures. And sometimes, so when you do surgery of this like extensive GBR, you must consider about the cleansing habit or not. So changing in the conventional GBR, we have converted. So from these cases, so sometimes the technology is especially about the engineering technology looks nice, but practically it's not so much helpful. So clinically, patient-oriented comfortness is very important. About also sinus 7 millimeters length is good enough. Also, osteoceanic collagen is a bicortical fixation, and the crystal approach is 7 millimeter length is good enough. At first, we are trying to select the wide diameters, but at first, we are worried about that. So, with the relatively wide diameters, but nowadays, even to more 3.5 millimeter diameter is good enough. So, through the temporary to the finals, sorry. This is overlapping together, so I'm sorry. But I will if you select some more longer implant, there is much more potential of the perforation and some artery ruptures. So if you select at the time, I will pass them and I will share together with you in future. So okay, okay. Left side is, if you select longer implant, is much more traumatic approaches, but right side, if you select the 7 millimeter short implant, is a much less surgical trauma to the patient. There is a very big, very interesting comparison between the longer implant surgery and the shorter implant surgeries. Is a left side during the crest approach, there is a perforation, so I converted it into the right approaches. So there is a much more bigger flaps for the sinus elevations, but right side is with the 7 millimeter low short implant is flap design became to be much less. Also with the short implant, much less complication and much less bone grafting and much less discomfort to the patient. So even in the sinus, if you select the short implant, is a surgical to be very simplified. So that's the reason we have developed the sinus simple new kit compared to the previous DASC kit, because previous DASC kit is very common in the worldwide, and most of the universities in the world use the DASC kit. But with this, through this video, you can see that is the reason to develop the DASC simple. With the DASC simple, is a surgery compared to the previous surgeries, totally became to be different, even into crustal approaches and also to the retro approaches. It's a very small, simple, and very early loading with the final processes. compared to the left slides, videos, and the right slide is much less discomfort to the patient. So with a short implant, much less complication and easier to do surgery. And also in the sinuses, diameter 3.57 millimeters are very helpful. After instruction and the implantation into the septum, little membrane elevated, so we did some bone formations. 6 weeks later, very into the septum is a very good bone quality. So nowadays 1 month final process is good enough. So in a case, is a bicortical fixation, very high stability. So sometimes less than 1 month's loading is with the final process is possible. Is a case, is a very good initial stability. So nowadays you are trying to reduce the time for the final processes within 1 month. Also in these cases, place the implant in the septum is June 17th. After healing, implant drilling onto the septum. Is a natural tooth. After the preparation is 1 day later final processes with the BTS concepts. And but implant at first is the temporaries. Also with the bicortical fixations. 27th, 3 weeks later. Final process is very early. So with the short implant, we became to know that is a very different view in the implantology. So 7 millimeter length, and before is a BTS for the freehandies, but nowadays the photogrammetry algorithm is very well developed. So also in the freehand cases, occlusion became to be very precise. As a 1 month's loading is possible, so nowadays we are recommended use the 1 month final process is possible with a bright implant system. And but in my office, clinical is offer 4 weeks lower, 2 weeks. So little bit challenge of the approach is in my offices. But with the temporaries, most of the case 2 weeks right loading. Yeah, also is a very similar bicortical fixation. We can do very early temporalizations. Both three, in this case, 2 weeks right temporalizations. So the reason I will presentation of the faster loading concepts, and because we usually follow the previous concept is waiting some months, but nowadays right design and the implant surface treatment development, and so the loading protocol can be changed. So especially in the upper molars, pressed into the implant in the septum area is a very early temporizations or also final treatment. So nowadays not yet completely, but 1 month's loading is possible with the drilling concepts, combined with the drilling, designing, and the fixture designing. Also in this patient, in the lower 2 weeks, final processes is good enough. Also, even the offers, yes, as you see, the less than 3 millimeters with the flap design is good enough. for the labial augmentation of them. And finished. So loading protocol continuously became to be changed for the oral loading. So sometimes even in the septal twist loading, with the final process before the complete healing of the soft and the hard tissue, it became to be possible to isolate the final processes during the waiting. The soft tissue became to be well. So in features with the bright implant system and the short and the low will be very heavy progress. In the surgical concept will be changed, and also they can be used for the orthodontics areas. Thank you very much for your attentions, and thank you very much for your visiting.
Vâng, xin được cảm ơn chia sẻ đến từ tiến sĩ bác sĩ Chung Sung Min và phần trình bày vô cùng xuất sắc của bác sĩ Trần Ngọc Hải. We are so thankful for your pursuing from Dr. Chung Sung Min and the translation by Dr. Trần Ngọc Hải. Và ban tổ chức cũng có nhận được cái câu hỏi qua bài báo cáo của Dr. Chung, và xin mời bác sĩ Trần Ngọc Hải tiến ra hội trường để hỗ trợ phần chuyển ngữ cho phần Q&A này ạ.
Maybe that so much familiar to the bright implant system is not would be many questions, but we share the information together. So in future, if you become familiar with bright implant systems, you will understand more. Thank you.
So we have some questions. The first question is when we will use the implant tissue level and when we use the bone level implant of the indication.
Usually we place the tissue level implant, because the tissue level implant is much more convenient to the patient, because compared to the bone level there is no so much pain. Also, I place the tissue level implant. I feel that tissue level is during the incision of temporary finals is much less pain to me. So tissue level is much more convenient to the patient. So over the 90% of tissue levels. But for the emergency profile, through the control of the depth control, we make even it more or less, and so we make a relative emergency profiles. But in a specific vertical augmentation or sinus elevation cases, paradigm at the time we use the level.
Như vậy cái implant mà ngắn mô men á, thì nó sẽ tiện lợi hơn cho bệnh nhân, tại vì cái quy trình đặt cũng như là cái quy trình phục hình phía sau thì nó sẽ đơn giản hơn và ít gây đau nhức cho bệnh nhân hơn. Nên thường thì ông sẽ ưu tiên sử dụng implant ngắn mô men, gần như là 90% các cái trường hợp điều trị của ông thì sử dụng implant ngắn mô men. Và bên cạnh đó thì implant ngắn mô men còn có một cái ưu điểm nữa là giúp chúng ta có thể tính chỉnh cái độ sâu của implant một cách đơn giản hơn. Tuy nhiên thì sẽ có một số tình huống nếu mà chúng ta nâng son kẹp xương, hoặc là những cái tình huống mà chúng ta cần có cái margin profile lý tưởng hơn, thì cái việc đặt implant ngắn khớp xương là sẽ vẫn cần thiết trong một số tình huống nhất định. Thì đó là cái phân tích của giáo sư Chung về cái đặc trưng cũng như là cái ưu nhược điểm của hai loại implant ngắn khớp bên và ngắn khớp xương. The second question is when we will scan the impression and when we will using the direct intraoral scan. Why we don't use the intraoral scanning for simplified?
Yes, we must know that some limitation of the intraoral scanner is very important, because with the however intraoral scanner continuously upgraded here without posterior support, and some is through the stitching menus images is some errors. And however, nowadays continuously upgraded in the technology, especially about the photogrammetry, so much better compared to the previous. But for the temporary is fine, and also if you use nowadays with the most advanced photogrammetry intraoral scan is fine to the straight line to the four crowns. But in a curved situation with the edentulous, it's still some limitations. So if you use the impressions, by the impression, and also scanning, either model scanner, or if you want to use the intraoral scanning in extensive curved situations, you can do direct that directly to the patient intraorally, and impression scanning is much more precise. So that's the reason. So you will meet. Also, you will meet in the future with many photogrammetry concept with some many scanning tools. But if you use the impressions, and impression scanning is very precise.
Vậy câu hỏi là khi nào thì chúng ta quẹt kiểu cao su và khi nào thì chúng ta quẹt trong miệng, và tại sao thì không quẹt trong miệng luôn cho là đơn giản. Thì như vậy câu trả lời của ông thì chúng ta thấy là ngày nay thì các cái công nghệ quẹt trong miệng nó ngày càng được nâng cấp, thì cái độ chính xác nó đang ngày càng tăng. Tuy nhiên thì về cơ bản thì cái việc quẹt kiểu trong miệng tăng cái cách thức là chúng ta chập dữ liệu ở từng vùng nhất định lại với nhau thì nó sẽ vẫn có các cái sai số, đặc biệt là những cái trường hợp mà nó không có các cái nâng đỡ ở phía sau thì cái độ chính xác của các cái máy quẹt trong miệng khi mà quẹt dấu các cái vùng mắt răng dài thì nó sẽ vẫn còn chút hạn chế. Và ngày nay thì cái sự đồng thuận thì như ông trình bày là chúng ta có thể dùng các cái máy quẹt trong miệng cho những cái trường hợp mà từ vùng đơn vị trở xuống. Còn những cái trường hợp mà dài hơn thì việc mà quẹt trực tiếp trong miệng thì nó vẫn còn đang hạn chế, nên cái việc quẹt dấu cao su thì nó sẽ cho chúng ta cái độ chính xác cao hơn. Bên cạnh cái việc là chúng ta vẫn có được cái sự thuận lợi của cái việc là lấy dấu với cái dữ liệu trực tiếp từ trong miệng và cái dấu cao su, thì đó là cái gợi ý. Tuy nhiên ngày nay thì chúng ta biết là cái công nghệ quẹt trong miệng với các cái công nghệ mới như là quan trắc tập thể thì nó sẽ tăng cường thêm các cái năng lực của cái việc quẹt dấu trong miệng, và trong tương lai thì việc chúng ta có thể quẹt dấu trong miệng trực tiếp những cái trường hợp phức tạp hơn, các trường hợp mắt răng dài hơn, hay là các cái trường hợp tất cả vùng phía trước và phía sau thì nó sẽ ngày càng trở nên khả thi hơn. Tuy nhiên thì ở thời điểm hiện tại thì vẫn ưu tiên sử dụng cái việc quẹt dấu cao su. Thế chúng ta quẹt dấu cao su chứ không phải là chúng ta quẹt màu hàm cái gì ha, tức là quy trình chúng ta vẫn là không có dùng màu hàm, nó sẽ số hóa cái dữ liệu của dấu cao su chứ không phải là số hóa cái dữ liệu độ mẫu, nên là vẫn rút ngắn được một bước. Thì đó là cái phân tích của giáo sư Chung về những cái ưu nhược điểm của việc quẹt dấu cao su, cũng như là quẹt dấu trực tiếp trong miệng, cũng như là các cái chỉ định và các cái gợi ý cho những cái tình huống lâm sàng trong quy trình hiện tại đang dùng. The third question is where we put the pin guide in the soft tissue or in the hard tissue.
It's a pin guide usually to follow the labial hard tissues from the of the mucogingival junction, also palatal sides together. So through that we can know the bone widths with the pin guide.
Thì cái câu hỏi là cái định vị bằng xương thì cảm mô mềm hay cảm mô xương, thì cái này là cái định vị này là cái định vị nó khác với cái chỗ chỉ hướng mà mình hay dùng. Tức là cái này nó sẽ gai với cái bằng xương mặt ngoài, bằng xương mặt trong, để mình hình dung được, tức mình không cần bật rạc lên, mình cũng biết là cái bằng xương mặt ngoài, bằng xương mặt trong nằm ở đâu, để mình nhét cái implant nó vào ngay chỗ giữa hai cái bạn đó. Thì đó là cái chỉ hướng mới của Dentium mới phát triển, tức là nó sẽ gai vào giữa cái bằng xương với lại là cái bằng xương mặt trong mặt ngoài. Sau đó là mình cắm implant vào ngay giữa hai cái đó thôi, chứ nó không giống như cái chỉ hướng thường.
Vâng, xin được cảm ơn phần.
Finally, thank you very much for your coming and attentions. And also, in my ages, I am also already 65 years old. So to share all of our information all together with the very young, promising doctors, very happy. Thank you very much.
Xin cảm ơn phần Q&A vừa rồi đến từ Dentium phần phiên dịch của bác sĩ Trương Ngọc Hải. Và vâng, kính thưa quý bác sĩ, thì chúng ta sẽ có 10 phút để giải lao, và chúng ta sẽ quay lại hội trường. Và xin mời các bác sĩ tiến ở phía bên ngoài hội trường, thì nên tiêu qua chuẩn bị check break phía bên ngoài ạ. Vâng, kính thưa quý bác sĩ, và chúng ta sẽ quay lại hội trường vào lúc 10 giờ 55 phút để tiếp tục cho bài giảng tiếp theo ạ. Và mời các bác có thể tiến về sân khấu để chụp hình cùng với